So, okay, so I will present to you just a part of cerebral arteriovenous malformation, because this is a very wide subject, very controversial actually because of the indication of the treatment. So I will go strictly directly to, I will skip all the introductions of the AVM, physiopathology, angioarchitecture, everything, and I will go for the indication, the actual indication of treatments of this vascular malformation. So this is rapidly the classification. You have malformation with efficience and without efficience. With efficience, it's the dural arteriovenous fistula, cerebral arteriovenous malformation, which is pial, and the Galilean vein malformation in pediatrics. So I will discuss only the pial arteriovenous malformation. Concerning the cerebral arteriovenous malformation, the ruptured one, it's a definitely indication for a treatment when it is possible, because of if it's the moderate risk. If it's a high risk, then we have to discuss what can we do. It's an emergency treatment if you have a mass effect, or if you have, as I will show you later, intranidal aneurysm or subependymal position, where these are very liable to rebleed very soon. Otherwise, we have to postpone the indication of treatment. After 1 or 2 months, still you have the resorption of the hematoma. This is an example of an AVM, frontal AVM, which bled with the angio-CT shows this arteriovenous malformation with huge venous drainage. And this is definitely an indication for immediate treatment. So this patient, as it was easy accessible for surgery, they evacuated the hematoma and the AVM, and this is the result after surgery, which was done at early stage. Another indication for early treatment, this is a patient of 72-year-old. Can you close the door, please? 72-year-old with intraventricular rupture of the AVM. You can see here, this is the rupture of the AVM, and you have an important mass effect on the posterior fossa and in a ventricular dilatation. This needed a drain, and this is the DSA. You can see this huge vein of drainage that is responsible of a mass effect on the ventricles with dilatation. So it was definitely an indication for a quick treatment, but this is not accessible for surgery. So what we can do in this case is that we can embolize this malformation, endovascular treatment. This is what we did. I can show you here, this is a malformation that was mainly due to high flow fistulas. It means that you have the artery that gives right away an access to the vein. So I will show you again this image, because here you see this is the injection in the fistula. This is without balloon, this is with balloon. So what we do is we put a balloon in the fistula, in the artery of the fistula leading to the fistula. We inflate the balloon, and then we inject the glue with the balloon inflated to control the passage of the glue, not inside the vein, just to close the fistula. So this is the static image. You can see when you inject here, you have a diluted contrast, and when you inject with the inflated balloon, so you can understand where is exactly the boundary between the artery and the vein. So you do not have any passage of the glue into vein, which can be risky, because you can make the patient rebleed if you occlude the drainage vein. So this is how we do it. you can see here is this is a double lumen balloon. It means you have two lumens with the inside the balloon, one for injection and one for inflation of the balloon. You inflate the balloon and then you inject the glue under the balloon inflated, like this is the case. And this is after injection of the glue. You can control your injection, and you can inject much more when you have the balloon inflated. And this is one session. You have the final control of this patient within one session, where we reduced a lot we reduced almost completely this AVM. And this is the CT of the patient before, and at 21 days, you can see that you do not have any more mass effect on the ventricle, but he had a drain. For the question for unruptured cerebral AVM, here comes the controversy, because some people say we should treat, other we should not treat. I think personally that every case should be discussed individually, depending on several factors. Mainly the arguments will be the age, the localization of the AVM, if it's in eloquent area or not eloquent area, if there is predisposing factor for bleedings, which I will show you later on. But the general trend now is to follow the Aruba trial, which says that the Aruba trial says that you cannot, you must not treat patients that had unruptured AVM, because the risk of the interventional treatment is much higher than the risk of the medical treatment or of the natural history of this pathology. Concerning the treatment, you have three possibilities: endovascular, surgery, and radiotherapy stereotaxis. The aim of the treatment is to completely cure the AVM, because some says that if you leave a part of the AVM, it is a risk of rebleeding. But sometimes we going to the end and trying to completely remove the AVM make the patient at risk for a higher morbidity mortality risk. The endovascular treatment is a first intentional treatment. Oftenly we prefer to make it under several sessions, so you allow the brain vascularity to adapt every time to the new system, because you close a lot of arteries. And the occlusion of the nidus by embolic agent. This embolic agent can be either glue or a non-glue. It's EVOH. It means that you can have onyx, you can have fill, you can have squid. These are a completely separate entity of embolic agent. You have to avoid to have the embolic material inside the vein, because you will increase the probability of bleeding of the AVM. Concerning the embolic agent, you have, as I said, either the biological glue, the NBCA. You have several brands now. You have glue brand. Histoacryl is the oldest one, and we do not use it now because it doesn't have the indication for use inside the brain. But you have the glue brand, the magic glue, and you dilute this glue with lipiodol, so you can see it when you inject it on the X-rays. Then you have the EVO. It's like onyx or a fill or squid, not fill. Fill is a little bit different. It allows you a longer injection, a more controlled injection, but you have to use a DMSO and a special microcatheter that is compatible with DMSO. The difference between the two is the glue, it precipitates, and the EVO, it sedimentates, so it goes and it makes layers on the wall of the artery, while the glue goes in the lumen of the artery, not on the periphery. So this makes a difference of the occlusion of the artery. This is an example of AVM treated with onyx. It's a frontal AVM in a non-eloquent area. This is the angio and before the treatment. And this is with selective catheterism of the artery of the AVM. You can see here how the onyx reacts when you inject it inside a liquid material, then it precipitates like this. And this is injection of the onyx and how it looks on plain X-ray after, and this is the final result of injection of onyx inside this AVM. Here is an example of injection also of glue. This is an example of injection of glue in a small occipital artery. This is the leading pedicle to this AVM. It's a single pedicle with a single drainage vein. This is, here it's the nidus. So this is the selective injection. Really, you have to go with the magic microcatheter in contact with the AVM, so to avoid the normal blood supply of the brain. And then you inject intranidally the glue. So you can choose the dilution of the glue by mixing the glue with the lipiodol. So when you how you say, you take the lipiodol and with different volume, and the volume of your lipiodol will give you the concentration of the glue, and the progression of the glue will be different if you have a concentrated or diluted glue. We prefer to do 1/3 glue to like 30% of concentration, because this allows you to penetrate very well inside the nidus of the AVM. This is the result at the end of the injection, with the AP and lateral view with completely resection of this AVM. Here is another example where we can use both glue and onyx, and I prefer actually when you have a bigger AVM to start to erode all the arteries that are in the peripheral of the AVM with glue, and finally go inside with the end pedicle with onyx. This is a very big AVM unruptured of the occipital area. This patient had seizures that are uncontrolled with medical treatment, and he's young, so we decided to treat him. So these are the first thing that we did, is to exclude all the fistulous pedicle of this AVM with glue. And this is after 4 sessions in total. We embolized him with glue, and finally at the end we finished with the onyx. And the onyx, you have to penetrate inside the drainage vein. When it is the last session, you penetrate inside the venous drainage and you completely close the vein. This is how you can manage to treat completely the AVM. Now, for the risk factors of bleeding, there are several risk factors of bleeding. History of bleeding, if the patient had bleeded before. A small AVM, this is controversial. Sometimes they say that smaller AVM can bleed more. Deep AVM, it's definitely a risk factor. Intranidal aneurysms also. Unique deep venous drainage increases the risk of bleeding, and stenosis of the venous drainage also. So when you see a patient in consultation and you have you have the MRI, you make a functional MRI also to see if it's in an eloquent area, and what you're going to say to the patient, how much is a percentage risk of bleeding of his AVM. So you have to make in consideration all the predictive factor. History of bleeding, deep localization, and deep venous drainage are the most important. So if it is unruptured AVM, this is the annual risk of bleeding that you can present it to the patient according to how many risk factor he has. If have no risk factor, this is 1%, 3 or 5%. If it's a ruptured AVM, the risk increases of re-rupture of this AVM accordingly to the number of risk factors that he have. Concerning the associated aneurysms, which are really very dangerous entity, I will show you why by experience. You can have associated aneurysm, sometimes we call it flow-related aneurysm because of the aspiration of the AVM, especially if there are big AVM. You have on the polygon aneurysm, you have pedicular aneurysms, and you have intranidal aneurysms. These are completely different from the very classic aneurysm that we know. It is quite often seen inside the AVMs. So this is how they look. And I will show you, this is a case of a patient that had bleeding, and you can see in the posterior fossa, and you can see that he has multiple small pedicular aneurysm on the feeder. You can see here in the 3D, these are multiple very small aneurysms. Here is the nidus and the drainage vein. And these small aneurysms are very susceptible to bleed, and I'll show you why. So we started to inject the NBCA inside the feeder, the pedicle, and while we were injecting this is the angio control, and this is the way of the microcatheter to go to the to go in contact with the nidus, and this is the supra-selective injection. And while we were injecting, before injecting the glue, look what happens. The patient bleeded because of the injection, only the injection of the contrast inside the microcatheter. These are very, it's like a blister aneurysm. They are very, very fragile. If you inject a little bit stronger, you can make this aneurysm bleed. So what you do in this case is, when you have an AVM with a small intranidal aneurysm, prepare always the glue beside you so you can react very quickly. If you have such a situation, you directly take glue and you inject glue. You have to close the pedicle unless the patient can really have a severe bleeding. So in this case, you have to inject a concentrated glue. This is the CT after injection of the glue for this patient. Another patient, this is a patient that I treated a few years ago. He was 40 years old, had epileptic seizure, weakness of the lower limb. He had difficulty to walk, and he insisted. We rejected him several times not to treat, and he insisted, I want a treatment. I said, this is an eloquent area, it's in a prefrontal area. So he wanted to be treated. It's a big AVM. This is a contraindication for treatment because you cannot cure this patient. Anyway, what happened is that we took the patient for a treatment, and I will show you an image that when you do the angio, you look always to the AVM. You don't look elsewhere. You look, where is the AVM, where is the aneurysm, and look In this case, look, this is the axis that we had. We took the internal carotid right internal carotid artery, and look here. Can you see this small aneurysm? It's distant. It's a anterocoroidal aneurysm, and it's a distance from the AVM. So we said, okay, it's not a problem. So what's going to happen? At the beginning, we didn't even see this aneurysm. So we went with the microcatheter to the AVM in contact with the nidus. This is the intranidal injection. We started, this was the first injection with glue. So we injected the glue very well, okay? No venous drainage, passage, nothing, and we retrieve the microcatheter, okay? And we do an angio control and look at this huge bleeding from this small aneurysm here. So at distance from the AVM, you could never imagine that it could bleed, but it bled. And this patient, what happened is a very severe backflow because the patient had a huge hemorrhage, intracerebral hemorrhage, and we could not even go back to treat this aneurysm because you can see here what happened in the cervical portion of the carotid. Because of the backflow, we couldn't get again inside the brain, and this patient died because of this small aneurysm. So small related aneurysm with AVM can be very severe complication. You can have bleeding, and especially this patient had a unruptured AVM. So if it happens again, I would not treat this patient. Lastly, the venous approach. This is another way of treatment of AVM. Now it's very fashionable. There are several doctors saying, yes, you have to do the venous approach. I personally did some of them, venous approach, but I do it really when I don't have any more choice. If I will show you, this is a case of bleeding of this patient, intraventricular bleeding with this AVM, very small AVM. You see, in the posterior part of the pons, and it's taken by very small arteries. It's a posterior thalamoperforators artery, which are very small. You can see here the axis can be really a little bit difficult, and you may not have to completely exclusion of this AVM. So here is the axis. We did a venous approach by the internal jugular. You go from internal jugular vein to the straight sinus, and then you catheterize. You catheterize the drainage vein of this AVM, and then you put two microcatheters, and one distal in contact with the AVM and one more proximal to do a Cooker pressure. And here is the final result after you inject from the venous side. But the problem is that this patient had bleeding after. And you see, he didn't have this bleeding before. He had only intraventricular, and he didn't have any bleeding in the thalamus. So he had a bleeding because most probably we left some small artery untreated, but you cannot see it. So the venous approach, even if here you can see that you do not have any more nidus and any more venous drainage, the venous approach can be very tricky, and I recommend to do it only if you do not have any more choice, if you don't have surgery or if you cannot do any arterial injection. Finally, the surgical treatment, it's only indication if it's you have a hematoma with mass effect, or if you have an incomplete treatment by endovascular and you have a venous passage of the embolic material, so you have to go and resect the AVM completely if it is accessible. There are higher complication rates with the surgical, especially in grade 4 and 5 from the Spetzler-Martin classification, with a higher mortality rate. And the last is the radiosurgery gamma knife. This the indications is when you cannot access the AVM either by endovascular or by surgery, if it's less than 3 centimeters, but it takes up to 3 years to be effective because it's a progressive fibrosis of this AVM, and you still have some 5 to 7% of complications of radionecrosis. Here is an example. This is the machine of the gamma knife, and here is an example of this was an AVM, unruptured AVM. We did this gamma knife, and this what happens after a few years. You have a radionecrosis of the brain at the site of the radiotherapy. So thank you very much for listening.
Thank you very much for your very nice presentation of Professor N.SOUROUR. So do you have any question from the audience, Professor N.SOUROUR? So I have one question. What do you think about the long-term follow-up after Aruba? What do you think about the long-term follow-up after Aruba result?
After Aruba, I think, personally, I think Aruba was a little bit biased trial, and it's very discussable now. Now we are doing a trial, not a trial, but we are putting in a registry patients to see if we must treat or we must not treat, if the treatment is available or not. So I think that we're going to rediscuss Aruba again, because some patient, as I showed you, if it's unruptured AVM and you have predisposing bleeding factors, I think it is an indication for treatment, especially if they are young patients. And this is why I started by saying that unruptured aneurysm, you should discuss case by case. You cannot give, you give a general way to follow up, but you can, sometimes you have to do it different. If you have a young patient with a non-eloquent area, a small AVM with small intranidal aneurysm or what, personally, I will go for treatment and not wait till he bleeds or whatever. So the follow-up of Aruba, I don't have any opinion on it.
Thank you very much. And we move next speaker. Xin trân trọng giới thiệu bài tiếp theo của